introducing our next speaker, Dr. Zelia Correa, who's a professor of ophthalmology at the University of Miami Health System and co-director ocular oncology services. Her interest is in ocular oncology and especially in melanoma and retinoblastoma. Kindly do take over the session, ma'am. Thank you.
Thank you so much. Thank you for the very honorable invitation. I offered a bunch of different alternatives for presentation, and it seems like the panel is very interested in looking at how I manage idiopathic choroidal effusion. As you can imagine, choroidal effusion is an entity that actually comes to me as a differential diagnosis. Many a times we see patients with small pockets of choroidal effusion, and most of the time, when they get to me, they really have this diffuse choroidal effusion. I don't have any relevant financial disclosures, but I do consult for Castle Biosciences and Immunocore here in the United States. So my objective is to present the surgical outcomes of patients with choroidal effusion and discuss the benefits of additional intravitreal therapy to enhance these results. So first, I present to you a patient, a 79-year-old woman with vision loss after tube shunt for glaucoma. And, the glaucoma doctors didn't really dilate her. She had a really small pupil. And, and the question was, when she finally complained about that vision loss and they saw these large elevated lesions, patient had a previous history of systemic, disseminated metastatic disease. They thought, well, these are metastases. The patient comes to me. Her visual acuity was 2100, but the ultrasound was very clarifying. It was very elucidative, where you can see the glaucoma shunt reservoir here. And very clearly, you can observe the choroidal detachments and the posterior thickening of the choroid. So, but I'm going to come back to that one. I want to show you another patient here. And this patient was a 78-year-old woman with blurred vision as well. Initial visual acuity, 2200. She had a bit of a pocket here of choroidal detachment that was more prominent, but she also had this diffuse choroidal detachment. She presented with, also some retinal detachment and nonspecific uveitis. She was a diabetic, hypertensive, and had recent weight gain. And then we'll talk about a little bit more about that in a minute. And her social history was non-contributory. She had a past medical history of cataract surgery, and she had been already managed by the other ocular oncologist here in the program with multiple injections of subtenon scanalog that was giving her temporary mild to moderate improvement, but with recurrence as soon as the steroid washed out. This was her OCT. You can already see some changes here in the RPE and Brooks membrane. You also observe, similarly to what you saw with the other patient, this part, here's the choroidal detachment. Here's more of a retinal detachment and the very visible thickening of the choroid there. So this is how we manage her. We did the classic scleral windows as described by Golden Payment many, many years ago, and they really work very well. The way I do it, I mark about 6 millimeters on each side, always posterior to the muscle insertion. As you're seeing there, I try to open a flap that is about 80 to 90% of the thickness you can see there. I want to see that graying of the sclera as I'm removing that tissue. And you notice that the important thing here is to really find a good plane of dissection. So some of us, it's a little bit harder. Those of us that were trained doing scleral buckles with, the old Scapin's technique, it doesn't seem to be that daunting. And here's the second one you're observing there. And so I open preferably 4 scleral windows, 1 in each quadrant. They're just showing how the scleral windows look. And at the end, I just cut it off. But I think the important thing here is to observe how thick the scleral wall is and the depth of those scleral windows. So this is the patient 1 month after surgery. You notice that significant pocket of choroidal fluid here is gone, and you notice significant improvement of the serous retinal detachment, which takes us to adjuvant pharmacological treatments that we can do to enhance those results. I personally don't like to use a lot of triamcinolone or triescence because of the peaks of intraocular pressure we observe in these patients. As I showed that first case, which is not this one, the patient had already a glaucoma reservoir, and it's pretty daunting to think that we're going to give them triamcinolone and then they might just do another peak of high intraocular pressure. So I favor using Ozurdex. I really like those implants. The dexamethasone does not increase the intraocular pressure so significantly, and it has a more long-term release of the medication, more constant. So here's the patient 2 months post-operatively. You notice the serous retinal detachment. Now it's very shallow. The choroidal thickness is improving. Here you can see a little side of one of the scleral windows. You notice how much thinner the eye wall is compared to this side. And you see the little Ozurdex right there. 2 months after surgery, we can see a significant improvement there for this patient, and very, very satisfactory outcome. Here's the patient 7 months after surgery with complete resolution of both choroidal detachment and the serous retinal detachment, and her final visual acuity was 20/25. For the other patient, I could only do 3 scleral windows because obviously supratemporally she had her glaucoma reservoir and I could not mess with that. I was fortunate enough that I was able to open the conj and manipulate the 3 other quadrants without disrupting the glaucoma surgery. Here's the patient 1 month after surgery with complete resolution. I hope you can remember those big pockets, almost kissing choroidals that you saw. And here is the little Ozurdex implant Vision 2030, and she is doing really well. And I want to thank you for the opportunity to share these 2 cases with you.
Thank you, ma'am. Fantastic cases and really fantastic surgeries, and the outcome were really beautiful. So some questions which I wanted to raise was, what is the end point of the scleral flap? As you showed, we need to see that little gray zone, whether that's the end point or you want to dissect much more deeper inside. So what would be your take on it?
So that's a great question, because early on, some people even went as far as really opening the eye wall and draining, physically draining those choroidals. I haven't really seen a substantial benefit to that, because it does add the risk for choroidal bleeding. So you can have a lot of complications if you drain, especially if you drain so posteriorly, because draining anteriorly is not going to help you. You really have to go post-equatorial. So in my experience, it really doesn't matter. Maybe it takes a little longer for that choroidal detachment to settle down, but it will eventually settle down. So my endpoint is really that kind of 80 to 90. I need to see that graying. And as I'm dissecting, the video unfortunately doesn't do it justice, but you start seeing fluid leaking out of that, of that thin sclera. So that's when okay, it's working. As I'm finishing the flap, I almost start, that kind of soreness there, it starts to fill up with serous fluid. So that's when I know, okay, this is really where I need it to be. I have in the past, for cases that there was a question of, choroidal lymphoma, or a patient had a history of systemic lymphoma, and there was some concern that, that the choroidal effusion wasn't really just a simple choroidal effusion, but it had a neoplastic background. I have opened at the edge of my scleral window and taken a piece out of that choroid. But again, it comes with a lot more complications. And I like to close it again, because I am trying to avoid the flip side of that, which is, hypotony. And, and if you have something leaking there, it may take a while to close. So I do suture that. But by and large, I think the benefit of not kind of violating the eye is that, number one, you don't have the risk of bleeding. Number two, you don't have a risk of hypotony or other complications, and it's a much more controlled surgery. I have a case that I wasn't able to share, in which the patient presented with a very thick choroidal detachment and a funnel RD. And so what I did for this patient is I staged it, and I went in, took the floor scleral windows, I passed a buckle, and then I brought the patient back about a week later when that that choroid was already kind of draining, already thinning out. And then I opened and I kind of opened the funnel and I reattached the patient. This patient, fortunately, is now, I think, almost a year out. And, I haven't taken the oil out yet because the patient is very insecure to take the oil out. But he's doing great. So that was a case that I thought, well, with this funnel RD, it really will be helpful to have a drier, thinner choroid in terms of having a successful reattachment. Thank you.
Fantastic. Yeah, thank you for the comments. Yeah. So if any other faculty or our colleagues have any questions, we can ask.
Zelia, congratulations, great cases. And just want to ask you about the Ozurdex. How you choose your patients that deserve Ozurdex in?
Well, currently I'm inserting an Ozurdex in every single choroidal effusion case that I do. And it really helps a lot. It helps also with not having to give the patient such long-term topical steroids. So if you consider the fact that there are some authors out there, some researchers that think that choroidal effusion may have an autoimmune background. I personally think that these cases, usually they have some peculiar historical points. A lot of them have had recent significant weight gain, some hormonal changes. And my caveat is that all of these patients, and I have done even bilateral choroidal scleral, windows, these patients have very short necks. So when they sit down and I see that kind of stout sort of physique and recent history of weight gain and everything, I always think, this is going to work really well. Now, there are a kind of a group of scleral effusion patients that don't have a thick sclera, but I have honestly not encountered that. I think that that's more related to like a pachychoroid syndrome or complex, but not the actual diffuse choroidal effusion.
Okay, thanks.